1 minute early. So, I'm Rachel Casey. I have been in DC for a long time. I went to GW for undergrad, medical school, and residency in obstetrics and gynecology. And now I am doing a fellowship here at Children's and across the street at Washington Hospital Center in pediatric and adolescent gynecology. Absolutely.
It's very important that everybody complete their evaluations as they go along. There's a colored piece of paper in your folder that really helps our speakers get some feedback and help us to improve the future.
So for pediatric and adolescent gynecology, which is kind of an emerging field, I'm lucky to have my program director here. So I got a lot of challenging questions in the last session, and so maybe if I can't answer them, she can. So make sure you ask away. Please interrupt at any time. I realize some of you have many more years experience than I do, and so if you have any pearls, questions, comments, just feel free to be a part of the talk. So we're specifically talking about OCPs, patch, and the ring. These are the learning objectives, so we're going to talk about advantages and disadvantages, mechanism of action, contraindications, how to start birth control, and when to use a backup method. Some of these slides or some similar slides were used earlier today, but just as a reminder that teen sexual activity, not many teens are having sex very young, but it increases almost exponentially as they get closer to 16, 17, 18, and 19. Teen pregnancy rates are highest in the South and Southwest, but if you look up at this little dot titled BC, teen pregnancy is a very, very big problem in BC. So this is a very pertinent day and symposium. The good news is that it seems as though there are more teenagers using contraception at the time of first sex, either condom or other method alone. So this is promising to us. And we can feel good, especially good about this, because there is a drastic decline in teen pregnancy, although maybe not in the district, but that's why we're here to work on that, right? There was a 61% decline from its peak in 1990, so that's pretty drastic. So we're going to talk about a little case on contraception. We're going to be continuing with Angela, who was a part of this morning's talk. She's a 16-year-old who says she uses condoms most of the time, which we know is not the most effective form, but it is the thing that really will protect against sexually transmitted infection. So what kind of additional history do we need to know?
Further define what most of the time means. You could ask, like, the last time she had sex, if she used the condom, 50% more or less.
Which will kind of tell you, hey, you probably need a different kind of birth control, a different method of birth control. Other things that are important to do in gynecology, we do a pretty in-depth menstrual history about how often they're getting their periods, how long they're lasting, if they're having a lot of pain during their periods. And this is really important because specifically the methods we're talking about today can help with some dysmenorrhea symptoms or heavy bleeding symptoms, and so that can help you kind of tailor what is the best contraceptive method for them. A good medical history is very important. There are contraindications to estrogen-containing forms of birth control. Just a couple are migraines with RA and DVT or PE history. So obviously getting a good medical history is important. Family history of blood clots, specifically first-degree relatives, if there's any underlying disorders, is important to know. And their social history. So what contraception have they been on before? And if they're not on it now, why did they stop? What was it about it that they didn't like? Or was it that they couldn't remember it? Or something like that. So that can help you tailor, again, the contraceptive choice. Again, with our teenagers, certain things are really important that affect what they might choose. Confidentiality is a big part of it, especially for the girls that we see. Do they want their parents to know or do they not? Do they want something that their friends would never find out about? Some of them will also come in and their friends come up with weird things that they heard. So one thing that I heard is the IUD makes your hair fall out. Has anybody ever heard other weird things, if you want to share them? That would be some funny things that people have heard. I'll try to think of another one. So side effects they might be concerned about. Cost can be an issue, especially if they want it to keep it confidential. If they don't want something to reflect in their parents' insurance, then you may refer them to a Title X clinic. So those are all different things. So, as you mentioned, I had unprotected sex 2 weeks ago. So, of course, the first two questions that usually come in when they come in to talk about contraception is, am I pregnant, and are you going to have to do a pelvic exam? So, the answer to the first question is, I have no idea, right? I don't know if you're pregnant. I can't tell you the answer to that right this minute. And do I need a pelvic exam? No. So you do not need to do a pelvic exam to initiate contraception unless they're having symptoms that you are concerning for sexually transmitted infection or a different problem that you feel that needs to be evaluated. But you definitely don't need to do it for contraception in general. This is a little table from the U.S. Selected Practice Recommendations for Contraceptive Use, and I love the title because I think it's very perfect. How to be reasonably certain that a woman is not pregnant. So you can feel, this is online, very easy to find. How can you make sure that we don't think you're pregnant, we can start your birth control pill today? So no signs or symptoms of pregnancy and meets one of the following criteria. So it's less than 7 days from the start of a normal period, has not had sex since the last period, has been correctly and consistently using reliable contraception, which this patient is not, is less than 7 days from a spontaneous or induced abortion, is 4 weeks postpartum, or is exclusively breastfeeding and amenorrheic. So as I mentioned, you do not need to do a pelvic exam. This is kind of a transition to show where the guidelines have gone for doing specifically Pap testing. The latest is out in 2012 from the U.S. Preventative Task Force and American Cancer Society, and this is also supported by our National OBGYN Society, that nobody needs a Pap test until they're 21 years of age, and the screening interval for girls under 30 is every 3 years. So Angela says, my friend just got a prescription for birth control. Can you tell me more about them? So OCPs are safe for use in adolescents. There are contraindications to them, and more of them come into play as women get older, specifically over 35, and if they have other health risks. But in adolescents specifically, they can be used very, very safely and can actually be very helpful with health benefits and also with other period-associated problems. So I'm going to talk briefly about progesterone-only pills and then talk a little bit more about the combination pills that contain estrogen and progesterone. So the mechanism of action for progesterone-only pills is a variable inhibition of ovulation, which leads me to the reason that we very rarely use this particular pill in adolescents, because it is not as effective. This type of pill needs to be taken every day at the same time, and even if missed by 2 hours, can be ineffective. And that is in part because of the mechanism of action, which, and you'll see when we talk about the combination pills, it's a little bit different. There's also endometrium, reduced cilia activity, and thickened cervical mucus. Some of the advantages, again, it's very safe. Progesterone is a very safe medication. There are very few contraindications. The way that it's taken is it's an active progesterone pill every single day for as long as they're taking this pill. So there's no period, there's no bleeding, and so it's something that's very predictable. It's immediately reversible when they stop it. The one downside to taking a pill that's active every single day is breakthrough bleeding. So many girls will end up with breakthrough bleeding. And as I mentioned, the efficacy is vulnerable. There is also some information about possible increase in functional ovarian cysts, and this is probably just because we're not suppressing ovulation consistently. And so every month when a girl ovulates, there is a cyst that contains the egg. And most of the time the cyst will go away, but sometimes can persist. These cysts are not dangerous, and they regress on their own, so it's just something to be aware of. So for combination contraceptives, there's a lot of good information about how they work. They thicken cervical mucus. Most of the data is about how they suppress ovulation, so we know very well that it decreases the GnRH pulsatility, the pituitary responsiveness, and suppresses LH, FSH, and importantly, suppresses the mid-cycle LH surge, which is what leads to ovulation. So that's the main mechanism of action. Other things that also contribute to the mechanism of action are decreased motility and endometrial changes, similar to the progesterone-only pills. So what are the advantages of combination OCPs? There are a fair amount of them. Efficacy is one of them. Specifically, when taken correctly, the failure rate is 0.3%, which is great. However, in the real world, the failure rate is about 8%. And you'll see that in the other methods that we use. They call it the typical use is somewhere around 8 to 9% for all of these methods. So as I mentioned, they're very safe. We'll talk about some other risks, but overall in this population, they're very safe. They're easily reversible after 2 weeks. They should ovulate normally, and the side effects profile is fairly low. Other menstrual benefits, decreased dysmenorrhea, so cramps with the periods are decreased. Decreased blood loss, so if you're having someone who has very heavy periods and perhaps is becoming anemic, this is a way to really help with that. And ovulatory bleeding, which is something we see with our girls, our menarchal girls who may have irregular, very, very heavy bleeding. We can put them on pills for a period of time to kind of get them through that initial pubertal bleeding. And then also decreased ovarian cysts. So if you have somebody who is having recurrent cysts, if you suppress their ovulation, theoretically you can be able to suppress future cyst formation. Other health benefits, there's decreased ovarian cancer, endometrial cancer. If you have someone with polycystic ovarian syndrome, you can help with decreased acne and hirsutism. Again, decreased endometriosis pain, and also decrease in benign breast disease. Some of the disadvantages are, I think the biggest one for our teenagers is daily administration, so remembering to take it every day. Again, I mentioned expense can be an issue. With the Affordable Care Act, there should be changes to that, but if folks want to keep it confidential and don't want to use their insurance, so it's not reflected in their parents' insurance, then that could become an issue. Most of the time, then there is going to be a Title X clinic that can cover it for them, but again, that leads to the access. So how are they going to be able to reasonably get access to the pills in an affordable way? Something else that's, I think, particular to this population is storage and access. So if they've decided they're going to take it at lunchtime every day, but they're in school, like how are they going to hide it or store it and take it out if they don't want anyone to know they're on it? What is the best way to do that? Some of the transient side effects, the ones due to estrogen, nausea, headaches, sore and enlarged breasts, and then the effects due to progesterone can be edema, abdominal bloating, and menstrual irregularities. Some of the risks associated with OCPs, some of the serious ones, one of which is hypertension, so this is something we should always be checking before we start them on combination OCPs, and should be checked again in about 3 months after starting it. If they do have an increase, then you should stop it, and usually it'll return back to normal, and talk to them about an alternate method. Some other things that we don't typically immediately think about are things like cholestatic jaundice, so it does impair transport of bile. Hyperkalemia, specifically with pills containing fourth-generation progestin, such as drospirenone, which is in gal. And then hepatic neoplasms, which are extremely rare, but just something to be aware of if someone's on pills and having this right upper quadrant pain. It's something that you should probably evaluate a little further. And then the one that everybody talks the most about is the clot risk. So it's really important to know that, yes, there is an increased risk, but it's an increased relative risk, but the absolute risk is actually quite low. And so for women under 20, it's about 0.5 in 10,000. And just to put things into perspective, pregnancy is much, 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 much more risky for clot risk than combination contraceptives. So in young women not on pills, the incidence is about 4 to 5. For pregnant women, it's much higher. And then you can see with the 50 microgram pills, which we don't really use very much anymore, it was a lot higher, but these days we use low-dose pills. Almost every pill that we're using is low-dose, and so the clot risk is much lower. Then a couple of other risks that I thought might be pertinent and interesting to everyone are pregnancy, MI, and stroke. But these are not actually real risks in this particular population. For pregnancy, there's not been shown to be any increase in birth defects, so if someone does if one of those 8 in 100 women is your patient that gets pregnant, we don't necessarily need to do additional prenatal testing, aside from making sure that it's a healthy pregnancy. For myocardial infarction, if they are young, healthy, non-smokers, there's no increased risk, and same for stroke. And this is very specific for like I said, healthy, young non-smokers. So things change a lot as women get older. Medication interactions is something that I think we all probably are aware of and need to be aware of, even if it's not when you're prescribing the pill, but also if you're admitting somebody on your service and you're looking through their medications, do you need to check levels, or is there some, so the combination of OCPs are metabolized through the liver, so they interact with cytochrome P450. So some medications will either lower the circulating hormones or increase the circulating hormones. So in these patients, you should really be talking about using perhaps a different method. And then it's really important to be aware of the medications all the way to the right, which actually will change the amount of medication, not necessarily the hormones, but will change the medication, so you don't want to overdose them on lithium. So that's something that is important to be aware of. I'm going to talk briefly about the U.S. medical eligibility criteria. I've been told that there is a copy of it in your folder. This is an excellent, excellent, excellent resource when talking about contraindications for use with any type of contraceptive, not just the ones that I'm talking about right now. It's developed by an expert working group in the international family planning community with the WHO, so it's very well backed up. It basically classifies things from 1, 2, 3, and 4. So 1 is basically there's no restriction, and 4 is that it's completely unacceptable for the health risk. So I'm going to show you this very busy slide, but this is what it looks like. It's literally a 2-page document with really, really great information. For example, this is a close-up of one of the topics. So you can see that they list the conditions down on the left side, and then there's sub-conditions. And then what we're talking about today is everything in this first column, so combination pills, patch and ring, aside from the progestin-only pills. And then injection implant, IUD with a marine IUD, and then the copper IUD. So it's just a great way. It gets very, very specific. I had a question in the last session about, well, if they have a first-degree relative with a clot, what is it safe to use, and do you need to do bleeding disorder workup or clotting disorder workup on them? And there's actually a 3 times the size of this in here, the bottom of one of these, right here. This is all about BTEs. So it is very specific about why did they have the clot? Was it from surgery and being immobilized, or have they been evaluated for a clotting disorder? So it's a really good guide, and it's something that's easy to kind of pin up somewhere and have access to. Any questions so far? Getting tired? Ready for lunch? Yes.
How frequent is it that you prescribe in teens combination pills for non-contraceptive reasons for the other indications? Is that frequent, or is that something?
For what we do as gynecologists, we do it a lot. So for dysmenorrhea symptoms, if girls are missing school because of their dysmenorrhea, for heavy menstrual bleeding, we use it for polycystic ovarian syndrome. We use it for a lot of different things. So very commonly, yes.
And we actually use it as second line for contraception, because first line should be long-acting reversible contraception.
You're giving away my last slide. Any other questions? Okay. So that was a lot of information. So she's now, how is she going to take the pill? So she thinks she might want this, but how is she going to take it? So when to start? And the answer to the question is any time. There's not a right time to start. They talk about is the quick start and the first day start and the Sunday start. I think for a long time Sunday start was popular because it was like you remember to take it on a Sunday, but unfortunately pharmacies are closed on a Sunday, and if you're waiting until the last minute, then you're not on a Sunday start anymore. So if you are reasonably sure that they are not pregnant, you can have them start at the same day that you give them the birth control. They should use a backup method for 7 days, and the one thing that we should be checking before starting combination OCPs is blood pressure, and they should be coming back for another blood pressure check a few months later. For the progestin-only pill, same thing, anytime, and you actually don't need a backup method. You only need a backup method for 2 days. But again, this is probably not a great option for our adolescent group because it's not very effective. So the question is, how can I take them? So there's different ways to take them. The top right, I don't have a slide, I did have a pointer, but I don't know what I did with it, is the traditional way. So it's cycling of 21 days of active pills and then 7 days of inactive pills. There is kind of a movement towards shortened pill-free interval. I was reading some information about how after 7 days of a placebo pill, by the 7th day, about 10% of girls will have a follicle, so an egg that's starting to form. Granted, most of those do not result in a pregnancy, but that, in addition with other benefits from a shortened pill-free interval, such as decreased bleeding time, mostly decreased bleeding, potentially helping with anemia if they're still having heavy periods. So those are all benefits of using the shortened pill-free. And that's what this is down here, is the low estrogen 24. So there's 24 days of active and then only 4 of inactive. And then there's the extended cycle use. So this particular example is Seasonique, Seasonal, which I think there is a generic kind, but to be honest, we oftentimes use a generic regular cycling pill and just instruct them how to use it in a way that they can have continuous suppression of their periods if that's what you're going for. But then again, if they're already forgetting to take pills, are they going to be confused about how to take them? I don't know. So it's, again, very personal to what's going on with your patient. So what am I taking, she asked, because she's very educated teenager. So most of the pills have ethinyl estradiol. It's not that different. Long time ago, we had pills with 50 micrograms. Nowadays, we're using mostly low-dose pills, which are 20 micrograms. And then there are 4 different generations of progesterone now in the different pills. The first generations were tolerated very well, but very low dose, and women were having a lot of spotting. The second generation are things like levonorgestrel, which is in the Mirena IUD. So these are more potent and have a much longer half-life. The third generations, which are in a lot of pills now, such as levonorgestrel, are very low in their androgenic effect, and this is how they can help with acne. And then finally, the fourth generation, these are the things that are in Yaz, which have anti-androgenic properties. These are derived from spironolactone. And there is, there is information out there. I'm sure everybody's seen commercials and had millions of patients ask about the clot risk. So if there is a slightly increased clot risk, it's not significantly higher, again, compared to pregnancy specifically, but it is something to be aware of and to be counseling your patients about. And then what about Phasics? So Phasics are kind of like the historical pill. They kind of would mimic the menstrual cycle. We don't use a lot of Phasics these days, although they do have a benefit of decreasing breakthrough bleeding. So there are there's biphasics and triphasics, and I guess there's a 4-phasic now that came out in 2010, but I've never used it. I don't know if any of you have. So we mostly use the monophasics, which is the same dose of medication every day for 3 weeks or 24 days. As I've alluded to many times, the most important thing for counseling in this age group is adherence and what's going to be the best method for them and what kind of funny things can you come up with. So remember, do you put it by your toothbrush? Or most of our girls will put an alarm on their phone. And there's a lot of different apps for periods out there, and is there a way to kind of have a little ding to remind you when to take your pill? Encourage them to know that the side effects are usually transient, the things such as nausea, and then it's always important to talk about what to do if you have a missed pill. So if for combination pills, if you miss one, you're okay. Don't need to use the backup method, take it when you remember. If you miss 2, then you need to use the backup method for 7 days. If you miss 3, then you kind of need to start over completely. And I was just talking to someone at the end that there's actually the insert, of course, in the insert of OCPs, this is all in there, but there is a good section in there that's very basic. So I don't know if your patients will read them, but you can tell them. So any questions about pills before we move on? So she's saying, there's no way I'm going to remember to take a pill. You're crazy. I can't even remember to brush my teeth. What other options do I have? So the 2 other options we're going to talk about are the patch and the ring. The patch is 20 cubic centimeters, so this is pretty much what it looks like. You can put it, they can put it anywhere. It's something that's easy to hide under their underwear, bathing suits. It delivers ethinyl estradiol and a third generation. It's something that you can apply once weekly for 3 weeks and then have a patch-free week where you have a bleed. The failure rate with typical use, so this is not perfect use, this is what most women are, how they're, if they're taking it correctly or not. The failure rate is about 9 in 100, so it's pretty similar with the OCPs, which was about 8. For backup, if they are on the patch when they're supposed to replace it after 7 days, if it's on for more than 9 days, then they need a backup method. Or if during their patch-free week it's off for more than 7 days, then they need a backup method. And again, if it fell off or they took it off for some reason and it's been off for more than 24 hours, they should also use a backup method.
For how long?
For 7 days. It's kind of a theme. So the advantages, again, weekly regimen, so you're not remembering to have to take a pill every day. It is pretty forgiving, you know, leaving it on for 2 extra days. That's, I would say, pretty forgiving compared to other things. It's rapidly reversible. 86% of women will ovulate after the first month. It adheres well. It's verifiable. They know it's there. They know they're not missing a pill. They can show their partner that it's there. And it doesn't interfere with intercourse, which sometimes the ring can, so that's important too. Disadvantages are similar to the pill, so expense and access, the risks of estrogen. There is a risk that the patch could fall off, which is about 2%. Some girls really don't like skin irritation. You know, some in the teenage years are vain and think that that's gross and sticky, so they may not like that. Another disadvantage is it needs to be sort of room temperature, so they can't like forget to leave it in the car for a couple days. And then one thing that I think is interesting and important to know is the efficacy is reduced by higher BMI. So there have actually been studies showing that in girls that weigh greater than 90 kilograms, that there's lower serum ethinyl estradiol. One thing that I'm sure most of you have heard about is that there is a slightly increased risk in clotting, and as this slide addresses non-fatal clotting with patch users. And these are just two of the bigger studies that were done. One showed that both of them showed that there was an increased risk in patch users when compared to OCP users. The first one showed a slightly increased risk, and the second one showed a much higher increased risk. So I think it's something, again, you're tailoring the birth control to your patient. So if this really does seem like the best method for them, then this is still an option. It's just something that they need to be aware of. So now she's worried that she doesn't like the stickiness and she thinks someone might see it at school. So what else is there? Yes?
Question. Are there any places she needs to avoid, like breasts or the fatty tissue?
It should not go in the breast, but it can really go anywhere else on the body.
Okay. Even like the waist?
Yeah, the waist, the abdomen, the back, the buttock, the arm, the shoulder.
So the only place you should avoid is breast?
And probably not the face. There we go. Yes?
For this girl, is the problem the dosage that is not sufficient? And if that's the case, can they put 1.5 or 2, or is there different dosage?
Yeah, it has to do with the absorption and, yeah, with the way that it's metabolized in the adipose tissue. So if there's extra adipose tissue. So I've never heard of doing anything extra. I would just encourage them to try a different method because there's so many different methods out there now. Any other questions about the patch? So the ring is a really, really great option for somebody who is not afraid of using it. I think in this age group there may be girls who are afraid of it, but it's something that you can teach them how to use in the office and show them that it's very easy to use, and they may feel more comfortable. So this is something that is inserted into the vagina. I should have put a picture of where it sits, but it basically sits it sits up high around the cervix, so you don't even have to, you basically, all they have to do is just kind of shove it in there, and it situates itself where it needs to be. It can be inserted for 3 weeks, and then they can have a ring-free week and have a bleed, or there's also the option to use it continuously if you're trying to suppress periods. Again, the failure rate with typical use is about the same as the others, which is 9 in 100. And if the ring falls out in the first 2 weeks, it just needs to be reinserted. If in the 3rd week, they can either allow themselves to have a bleed or insert a new ring. And for both of these, they should use the backup method for 7 days because you don't know when it fell out. I mean, they may know when it fell out, but they should have put it back in. Some of the advantages and disadvantages, so it's very effective. It's simple and easy to use. It's very private. No one is going to know that it's there except for them and perhaps their partner. Rapidly reversible, like our other methods. Again, it has the benefits of the combination OCPs, and it doesn't interfere with intercourse. Some partners will feel it, but they can take it. You can take it out and have it out safely for 3 hours, which I wouldn't necessarily recommend just because they may forget to put it back in, but it is an option. Some of the disadvantages are monthly administration. So it's still something that they have to still have remember to get it refilled and pick it up. There's side effects of estrogen. I mentioned that they may feel it during intercourse and possible comfort with insertion and removal. There are some women that have some vaginal irritation or increased discharge, and there's a very low risk of ring expulsion. So now she asks you after this long, in-depth talk, what is the best method for me? Yes, no, go ahead.
If a patient has a continuous yeast infection, but you wouldn't recommend the ring?
I wouldn't not recommend the ring. I don't think, I mean, having recurrent yeast infections is not going to be a contraindication per se, but again, you kind of have to like tailor it to the patient. So if they're having vaginal symptoms, is it really a yeast infection that they keep having? Is it proven on culture, or is it just irritation? In which case, maybe having another, like a foreign object in the vagina is not a great idea. You know what I mean? I don't think there's not a proven contraindication per se, but maybe it's not something that would be best for that person, if that makes sense. Any other questions?
And the effect is local or systemic?
It's systemic.
Only systemic.
Yeah, so it's, I mean, it's just like if you put a medication in the buccal mucosa. The vaginal mucosa is basically, what do I try to say? Yes, yeah, exactly. So what is the best method for Angela? And the answer is obviously it's up to you. So it's personal circumstance. What's their medical history? What's their family history? What are they most likely to use consistently? What's most likely to prevent pregnancy? And how do we address their issues of confidentiality to their family, their friends, and whoever else they may want to keep it confidential for? The two of the resources that we use pretty commonly, the first of which is youngwomenshealth.org. It's a very, very excellent website for patient information. It has a really good section on contraception, and we print out those patient information for our patients very, very frequently. And then the Bedsider is kind of a fun, interactive website that's through the National Campaign to Preventing Pregnancy. And that's also like they have like cartoons and videos and stuff that are kind of funny for people to read. And finally, in my closing, I would not be a good OBGYN if I did not mention that as a group of OBGYNs nationally, we really feel that adolescents should be encouraged to consider using long-acting reversible contraception, specifically IUDs and implants, because as quoted from their recent committee opinion, that they are the best reversible method for preventing unintended pregnancy, rapid repeat pregnancy, which is a rate of like 20%, which is really high, and abortion in young women. So we're doing a lot of IUDs and implants in adolescents. The adolescent medicine group here is doing a lot of implants, I can tell you, because I talk to the pharmacist about it all the time. So it's something that's really effective. They don't have to remember, and it's really safe. So if you already went to the LARC tech, you already heard that. And there's some more resources. And that's it. Yes.
How do you write prescriptions for patients when you want them to like take 2 days at a time?
Yes. So we write 56 pills in 42 days. Which I always forget, but yeah. Because you can write it, dispense 3 pill packs. Because if they're taking it continuously, that's all.
Do they get it dispensed? Because I feel like a lot of times we have to do like prior auth and all that kind of stuff when we try to do anything outside of the 28-day cycle. Yes, there are issues with that. The way that we've been writing them,
We haven't gotten a lot of issues with that, the way that you write it that way. I mean, it's probably mostly an insurance thing because you know how if people are trying to get 3 months at a time, but this really isn't 3 months at a time. This is maybe 2 months, you know. I don't have a great answer for that, but I do think now that Susan Cal's a generic, so that's an option too. But again, like I said, we rarely use that. We really just use just a regular pill and write it.
It's rare that we have to get pre-authorization. You write 56 pills every 4 days, 42 days. That's the problem. They come get it and they're not done with it. If you write 56 pills in 42 days, then you also get the placebo. Yeah, but it's every 42 days. So you get a new packet in 42 days, not 56 days.
So they can refill it earlier. Did you have a question?
Yes, you just mentioned the IUD, or like the LARC. In terms of, you mentioned you were doing more of them, and I realized this is probably the other talk, but
No, this is what we do, so.
You said you're doing more of them. I was just wondering, why, has there been some changes that why you're doing them more? Or?
So many years ago, the IUD is the most common form of contraception used worldwide, but in the United States, it's like 1%. It's very low. And the reason is because years ago there was an IUD called the Delcon Shield, and the string on it was braided. And so there was an increased risk of infection. So a lot of people say, you know, teenagers, we can't use it in teenagers because of infection risk or things like that. But this is a new IUD with a very different string, and there's been good evidence to show there's not increased risk of infection if there's no active infection at the time of insertion. So when we insert it, we check to make sure that there's no active gonorrhea or chlamydia, and if there is, then we treat it right away. So I would say that so that's part of it, and so I think that there are a lot of women in general that are maybe, our generation probably doesn't know that much about the Delcon Shield, but older generations and specifically providers who were in that generation who don't think that teenagers or women who haven't had a baby should be having them, but we're kind of like dispelling that. And it's coming from our national organization, which is why I'm saying I've been doing the same amount of them because that's where I came from in my training, but our national organization is kind of passing this to OBGYNs around the country, and so hopefully we will be using more of them. That's a long answer. Any other questions?
When it came out, the ring used to come with this funny little timer that was like a timer that would like tell the family or the woman when she was supposed to take it out. Does it still do this? It's just a taxing question.
I haven't seen it.
Yeah, it was a little digital thing. One of my friends had one.
That's so
but it was the strangest thing. It would like beep in her house. It's beeping, and then she would find it.
That's really funny. I don't think they do anymore. Yeah. I thought it's a good idea. Stickers.
So that you know when to put it in. And this cider has a really good option for teens. They have a reminder section, so they can get text on their phones for like the pills, the ring, and the patch.
That is true. I'm really glad you brought that up. Okay. Thank you so much.